and get started if everyone's comfortable with that. So good afternoon, I'm Lupe Alonso Diaz, and I'm the President and CEO of Physicians for Healthy California, lovingly known as PHC. This is one in an 8-part webinar series to support GME naive health systems that are interested in starting a GME physician residency program. Before we get going, I'd like to pause and thank Christy Bird-McKee for her vision. It was her vision that there is strength in numbers. It was also her vision that as she and Butte Glen community is going through this process, that these experiences be shared and that everyone be able to benefit from those experiences and those lessons learned. We commend the Butte Glen Medical Society for convening this series, and PHC is honored to co-sponsor and co-partner the series with you. It should be noted that starting a GME program is by no means an easy feat. I'm sure Christy can tell you all about that. It's been noted that typically it can take anywhere between 1 to 3 years and also between $1 to $3 million to start up a program from scratch. So today's webinar series will be focused on state programs that can support GME naive health systems, that can support GME physician residency programs going through this process. So again, I'd like to thank Christy as well as the team for their vision and for partnering and co-partnering on this series. The next slide identifies what we'll go through in terms of the agenda. So in addition to introductions, we will provide a little bit of history and background on PHC. We will focus primarily on Cal MedForce, which is the GME program that is funded by Proposition 56. We'll also note some other GME activities that can support those individuals that are interested in starting a residency program. And definitely last but never least, Melissa Oman will provide a presentation on Song Brown, which is another wonderful program, a state-funded program that also supports GME residency programs. So with that, I will turn it over to Jennifer Turner, who is our Senior Director of Operations.
Thank you, Lupe. On the call, I also have Robin Simpson, who will be sharing the Cal MedForce program shortly. She's our director. You will also hear during the Q&A session, potentially from Christy. And then as Lupe indicated, Melissa will be discussing Song Brown. Next slide. So as Lupe indicated, we would like to share a little bit of history and background with you regarding Physicians for Healthy California. We were formerly known as CMA Foundation, and we had a name change and rebranding in 2018. We started in 1963 as a charitable arm for California Medical Association, or CMA. We disperse grants to medical students to support future physicians, and our mission is dedicated to improving community health, growing a diverse physician workforce, and promoting health equity. This is a list of current programs and past programs that we've supported. So our current programs, the 2 flagship programs, are Cal Health Cares and Cal MedForce, and you will be hearing about both programs shortly. In addition, we support medical student community leadership grants, as well as NEPO, or Network of Ethnic Provider Organizations. And on the right side is a few past programs that are listed or mentioned on our website. Next slide. So our focus is naturally from undergrad to med school comes into play of residency programs. So Cal MedForce does fund residency programs and slots. And our second program that funds practicing physicians and or dentists is Cal Health Cares. And we'll be sharing a little bit more about Cal Health Cares as well as Cal MedForce later in the slide. Next slide. So funding comes through Proposition 56. So in 2016, CMA, CHA, and SIEU, Union Healthcare Workers West, sponsored Proposition 56 It was then approved by voters and supports physician workforce development. Proposition 56 allocates $40 million annually towards GME to sustain, retain, and expand primary care and emergency medicine residency positions. In addition, we have the loan repayment program that is instituted to recruit and retain providers in Medi-Cal, providing up to $300,000 in loan repayments for a 5-year service obligation. I'd like to take the opportunity to introduce Robin Simpson, who is our CalMed Force Program Director.
Thank you, Jennifer. So I'll talk a little bit more about the CalMed Force program with the intent of and hoping that either on the call today or future listeners are eligible applicants for the CalMed Force program or future eligible applicants for the CalMed Force program. So as Jennifer mentioned, CalMed Force is our GME grant program funded by Proposition 56. The program is committed to growing a diverse physician workforce by supporting, incentivizing, and expanding graduate medical education in California. Our goal is to grow and strengthen the physician pipeline to meet the demands of our growing patient population in California with a special focus on medically underserved areas and populations. So how do we do that? Eligible applicants are residency programs here in California, either allopathic or osteopathic, must be within our 5 disciplines. These are focused on primary care. The eligible disciplines are currently family medicine, internal medicine, obstetrics and gynecology, and pediatrics, as well as emergency medicine. Programs must be accredited by the ACGME. And I want to pause here because programs must be accredited by the time of contract execution. What that means is if a program is close to the end of the accreditation timeline, meaning they're close to accreditation, knowing that they'll receive accreditation by the time of the contract execution date, which is typically a little less than a year out from the application period, we definitely encourage those programs to apply. And if awarded, we will just ensure and verify that they have received initial accreditation at the time of the contract execution. So just wanted to mention that since we know we do have some listeners that are in the process of being accredited. And we do prioritize programs that serve medically underserved populations and areas. This slide shows the funding to date that we've provided in our first 2 application cycles. So we have awarded over $76 million to date. We are actually about to award our 3rd cycle, so those numbers are not included in this slide. But keep in mind that that number of 76 million will go up by a little more than 38 million when we award this cycle, which should happen by the end of this month. Our cycle for 2020-2021, we just had our application cycle close in September. Like I said, we are preparing to make award announcements before the end of the month. But this is to give you an idea of what the funding allocation typically looks like. So here are our 5 disciplines. Of the $38 million available annually, 25% approximately goes to family medicine, with each of the remaining 4 disciplines receiving 18.75 in funding. And this is subject to change year to year due to the fact that this is these amounts are determined through our advisory council and governance process. Programs apply for funding by resident position. So the program will identify themselves as either a new program, existing program, or expanding program, and may apply for the resident positions to go along with that. So for existing resident positions, we award $50,000 per resident per year. For expanding positions, $60,000 per resident per year. And for new programs, new resident positions, I should say, $75,000 per resident per year. Programs can apply for up to 5 resident positions, and it can be a combination. For example, an existing program may apply for 3 existing positions, but then they were also approved to add 2 positions, so they could apply for 3 existing and 2 expanding. Our application cycle is typically in the fall. We try to make the application process as simple and streamlined as possible. That is a goal of our program. Applications are auto-scored, so they are not subjectively scored. They are auto-scored through our online application. Applications are scored based on the scoring matrix that is transparently shared prior and during the application cycle. It is within our grant guidelines, which are posted publicly on our website, calmedforce.org. Applications are ranked relative to other applicants within the same specialty. So for example, a family medicine program will be competing, so to speak, with other family medicine programs. So the competitiveness may vary year to year depending on how many programs have applied that year. CalMedForce may award full, partial, or no funding to an applicant based on the applicant's score and ranking within their specialty. And once again, we emphasize that programs definitely apply every year, even if they were not awarded in a previous year. They may get a different score, there may be a different number of applicants, and so they may still be competitive even if they were not previously awarded. All applicants receive their final score following the close of the application cycle after applications are reviewed by staff, and then award announcements will be made in late November/early December 2020. As I mentioned, for this cycle, we are aiming to make our award announcements by the end of this month. Quick overview, since the awardees are not publicly shared yet, I can share, however, a snapshot about our application cycle. As an example, for this cycle, 2020-2021, we did have 122 applications, and 101 of those will be awarded. So just wanted to highlight that there is a very good chance that programs are awarded. So we do encourage all to apply that are eligible. This is also a quick overview of our 3 application cycles, including the most recent one in terms of number of programs awarded by year. You can see our first year was 2018-19, then 19-20, and then of course 2021. And I just wanted to note here that our current cycle that we're about to announce is awarding the largest number of residency programs. So we're very excited about that. And same with residency positions, we're awarding the largest number of residency positions for this current cycle. This is also, once again, a snapshot of our data for 3 years. So you can see here, number of new programs that were awarded, number of expanded programs that were awarded, a number of existing programs that were awarded. And that's, of course, once again, because our goal of our statute is to support not only new programs, but to sustain existing programs and expanding programs as well. You can see we did, once again, fund the largest number of new programs this application cycle. So I just wanted to point that out. The map shows where our awardees for the first 2 cycles are located. So you can see we are throughout the state, and we would love to get into some of these areas that have the yellow, the physician shortage areas. So that is another goal of our program. And at this point, I'd love to turn it back over to Jennifer to talk about some of our other GME related activities.
Thank you, Robin. So I get the opportunity to share a few facts as well as some additional opportunities related to graduate medical education. Next slide. So unfortunately, there's an unknown of GME naive health systems, i.e. community clinics, potential consortia that we're unaware of the exact number. We do know, as Lupe indicated earlier, that the GME, in order to start a new GME program, it takes approximately 2 years and $2 million on average to complete, which is very time-consuming commitment, as well as costly. $2 million is quite a bit of large leverage needed there. There are state programs that have funding available, but there's certain limitations in the funding. So we have 3 examples here. And so with the OSHPD WET plan as an example, that plan is utilizing a pay and reimbursement model, meaning you have to fork up a little bit of money and then go forward and reimburse. CalMed-Force, as an example, also does require a program to be ACGME certified at time of signature. And I'm sure there might be some other limitations with Song Brown that may be shared a little bit later with Melissa. CalMed-Force is exploring solutions to help support GME startups. So there's some research being conducted behind the scenes, as well as potential funding opportunities for to be introduced ideally sometime next year, assuming things come to flourish as we anticipate. Next slide. So there's currently 170 ACGME residency programs in primary care and emergency medicine in the state of California. We know that the demand for residency placement is greater than residency program slots available. If we had more slots, more programs available, certainly we could have more residents here in California. Currently, there's 136 Medicare GME naive hospitals in California and only 31 psychiatric hospitals in the state of California. Next slide. So recently, Physicians for a Healthy California sponsored an AMA or co-sponsored an AMA GME Innovation Summit. It was a national virtual conference that brought leaders together across medical education consortium to explore and discuss ideas related to innovation, driving systematic change. We actually presented a webinar titled Developing a Residency Program, Best Practices and Funding Opportunities. Within that presentation, there was research shared related to a comprehensive feasibility study and residency workforce, as well as some best practices related to needs assessments. It's identifying stakeholders and funding opportunities. During that webinar, we were also able to share CalMed-Force's impact in some of the data that you just viewed from Robin's presentation. Next slide. In addition, there's this webinar series, as Lupe indicated, it's 8 webinars. It's a series of webinars that are free. They offer innovative technical advice and solutions to meet rural California's critical access to care needs. Our hope is that physicians, practice managers, and providers can expect to learn fundamental elements of preparing for clinical facilities, to successfully design a medical residency program. The webinar series is taking place monthly through March of 2021 and is hosted by Physicians for Healthy California, as well as Butte Glen Medical Society. For folks that are interested in continuing to join or sharing this information with others, registration does have to be done through cmadocs.org/GME webinars, and any of the past webinars that you might have missed are available as well there and can be viewed. Next slide. This great opportunity was shared with us related to an RFP that Mathematica released. The application or the due date is December 15th, so we have a little over a month. Mathematica is offering an RFP to request funding for those folks that are interested in having a GME feasibility study completed. Funding is being conducted or provided by California Healthcare Foundation, CHF. And if you'd like more information related to that, you can go to our website under calmedforce.org. On the bottom low corner, you'll just look for resources and you can find out additional information regarding Mathematica. Next slide. So before I share the Cal Health Cares slide deck here, I just wanted to advise those that are on the call, the reason why we incorporated Cal Health Cares, which is our other flagship program, is because we were hoping that this program can be used as a recruitment tool. So an opportunity for residency programs to share with their residents that will be graduating soon. And you'll hear a little bit more about Cal Health Cares and how it might benefit a recruitment process. Next slide. So through Proposition 56, there's $340 million allocated for Cal Health Cares, the Cal Health Cares program for a 5-year span. The way that money is broken down into 2 buckets, physicians and dentists. For physicians, there's about $290 million allocated for physicians, which equates to $58.6 million annually. Historically, we've been able to provide funding to 195 physicians per year. And that is based on an assumption that the entire allocation that's available, the $300,000, is utilized for loan repayments. Meaning if an individual applies for a loan that's less than that, naturally there's more money to spread further to other applicants. For dentists, we have $50 million allocated, which equates to about or approximately $10.7 million annually. We've been able to fund or support loan repayment for 36 dentists a year on an average. Next slide. So this slide really shows you the program requirements. The big one I want to point out is highlighted here in green, and that is one of the primary requirements, which is that we do ask applicants, or awardees, I should say, to maintain at least 30% Medi-Cal caseload and within 10% of the Medi-Cal caseload proposed within the application. So if an individual indicates that they are going to achieve and sustain a Medi-Cal caseload of 70%, they do need to be within 10% of that Medi-Cal caseload at the bare minimum of 30%. In addition, they must have a current and unrestricted license to practice in the state of California. They must have graduated from a dental school, physician, or dental residency program and or completed a fellowship within the last 5 years, must be a Medi-Cal provider in good standings. They must be in good standing with their educational loan as well. And they must have existing educational debt incurred related to medical education and not participating in any other loan repayment program or practice support grant. Next slide. So for funding options, there's really 2 buckets when it comes to Cal Health Cares. The first one is loan repayment, which we just discussed. So it is for eligible physicians and dentists. It does, for 5-year service obligation, allow an individual to be granted up to $300,000. We did talk about the Medi-Cal caseload requirement, as well as the fact that they would have had to graduate or complete their fellowship in the last 5 years. The second funding option is the practice support grant, and that is available to eligible dentists. Similar dollar amount, so it can grant up to $300,000, but the service obligation is a little bit longer. It's 10 years. In addition, they could have graduated or completed their fellowship program within the last 15 years versus 5 years. And the goal for them, or their objective or requirement, would be they must be willing to expand and open a new practice relocate current practice or establish a new practice located in one of the many targeted counties that we're focused on. And they also must maintain at least 30% Medi-Cal caseload and within 10% of the Medi-Cal caseload proposed. Next slide. So here's a couple engagement opportunities for those on the telephone or those who are listening to the webinar. So naturally, the big one is to apply for the Cal Med Force and or Cal Healthcare's programs. We do have a pretty stringent governance process, and we would love to encourage participation on the advisory councils, as well as we open up the opportunity for folks to review and score loan repayment applications. Annually, we hold a summit it's a NEPO summit. We're going to be conducting our 18th year annual summit next year, as well as we have some reviewing and scoring opportunities for mini grant applications, as well as future funding opportunities that may exist. Next slide. And this is our contact information. So for Cal Med Force, there's the website. You can certainly please view and surf through. All the information I've shared is present on the website, as well as the email address and telephone number for the team. Next slide. And you've heard from Lupe Alonso Diaz, who's our president and CEO, myself, Jennifer Turner, as well as Robin Simpson, our Cal Med Force program director. And I'd like to thank you. I'd like to turn it over to Lupe to introduce our next presenter.
Thank you, Jennifer. Thank you, Robin. You've heard a brief overview for those of you that just joined us, a brief overview of how to leverage Cal Med Force, the GME Grants Program, as well as Cal Healthcare's the Loan Repayment Program to further support those local efforts in terms of creating a new residency program. And of course, no presentation would be complete without our sister program, older sister program, if you will, Song Brown. So thank you, Melissa Omond, for presenting. Melissa Omond is one of the managers at the Song Brown program, and she's been someone who has been a true dedicated public servant in this space. So thank you, Melissa, for joining us today. After Melissa's presentation, then we will do question and answer. Melissa?
Thank you very much, Lupe, for your introduction. I truly appreciate your kind words. Good afternoon, everyone. My name is Melissa Omond, and as Lupe indicated, I am the Song Brown Program Manager, and it is my honor to discuss the oldest state-funded GME program in California, the Song Brown Healthcare Workforce Training Program. The Song Brown program was created by legislation in 1973 to support family physician residency programs. Over the years, the program has expanded. Can we go to the next slide, please? I'm sorry. Okay. So over the years, the program has expanded to include family nurse practitioner, physician assistants, registered nurse programs, and most recently, internal medicine, OB-GYN, and pediatric residency programs. While the program has continued to expand during the years, the focus is always primary care. Regardless of the discipline, the statutory priorities for each applicant is the same. Each of these statutory priorities are evaluation criteria and make up the largest number of points available to any one applicant. So starting with clinical training in areas of unmet need, the Song Brown program expects applicants to provide training and experience to all of their residents, exposure to underserved populations during their time in residency. We also expect that program applicants encourage their graduates to practice in areas of unmet need once they have completed their residency. And the other expectation is that each residency program recruit and retain underrepresented minorities. To further these goals, we work with a 15-member advisory board that provides expertise on healthcare workforce issues, sets policies, and recommends awards. Next slide, please. All right, so for Song Brown, we have 4 program funding categories. Those being new PCR programs. So a new PCR program for Song Brown is a program that meets one of 2 criteria: has either applied for sponsoring institution accreditation or will have applied for sponsoring institution accreditation 30 days prior to the annual PCR funding meeting. Our meetings typically are in August or September each year. Or it could be a program that has obtained residency program accreditation, has no first-year residents at the time of application, and has not received any prior Song Brown funding. New PCR funding is a one-time funding. You are a new PCR program one time in the eyes of Song Brown. The other funding category that we have is teaching health center funding. This is a long definition, but a community-based ambulatory patient care center operating a primary care residency program. The sponsoring institution must be a residency. The sponsoring institution of the residency program must be a qualified teaching health center or an educational consortium that includes a health center. The third funding category that we have is existing program funding. So that is a program that is accredited by the ACGME. I realize this says AOA still, but for now, it's the ACGME, and will enroll at least 1 class by July 1st of the year in which they are submitting an application. Excuse me. And then we also provide funding to programs that are looking to expand. And our Song Brown's definition of expansion is a permanent increase in the number of ACGME approved categorical primary care residency slots for an existing primary care program. One of the requirements is that you have to provide a letter at time of application submission stating that the ACGME has approved your expansion. Next slide, please. All right, so since 2017, we have received $31 million annually from the state's general fund to award these 4 categories of funding. For new programs, we have $3.3 million annually, and these funds are really to offset the cost of starting up a residency program. So we are offering to provide you funds up to $800,000 to achieve accreditation. The disbursement of those funds are you put out the funds to receive accreditation and then turn around and ask us for reimbursement of those costs. You will only receive reimbursement of those costs once you have successfully become accredited. Next is the teaching health centers. We receive $5.7 million annually to fund recognized teaching health centers. Recently, we reduced the dollar amount per slot for teaching health centers. We were funding at $170,000 per filled first year slot. We just reduced that to $125,000. And prior, we had no maximum on the number of slots you could ask for. We recently lowered that down to 6 slots. Once you are awarded and you receive your grant agreement, upon full execution of the grant agreement, we will provide you with 70% of those funds up front, and then the remaining 30% will be paid out at the end of your grant agreement term. For expansion slots, these dollar amounts, we receive $3.3 million annually. These dollar amounts are spread out over a 3-year period to support at least one resident of a PCR program that has permanently expanded. You can receive up to $300,000 per first year slot for no more than 3 slots. These dollars are paid out quarterly in arrears to each of the awardees. For existing slots, again, this is, for this program, we receive $18.7 million. And that again is spread out over 3 years to support at least one resident of an existing PCR program. Programs can receive $125,000 per first year slot with 5 slots maximum. And that also is paid quarterly in arrears. Next slide, please. All right, so for Song Brown, organizations can apply for multiple funding categories with one application. The only exception to that is new programs. New programs, applicants will fill out a separate application because we don't know anything about these programs. All of the questions related to this application are going to be qualitative. Like I stated earlier, you are a new program one time. So you complete your application. If you receive funding, and the next year you can come back to us and apply as an existing program. So those programs, the remaining 3 funding categories, existing slots, teaching health center, and expansion slots, you can apply for all 3 of those in one application. So if you are an existing program that happens to also be a teaching health center, and you also happen to be expanding, you can submit one application for all 3 of those funding categories. And that information in those 3 applications, or for those 3 categories, I should say, will all be quantitative information. Next slide, please. All right, so just some key highlights. As I stated earlier, Song Brown funds institutions that train primary care health professionals to provide healthcare in medically underserved areas. The focus always being primary care. We have approximately $31 million in state funding annually to support the family medicine, internal medicine, OB-GYN, and pediatric residency programs. And our next application cycle opens April of 2021. If you would like to apply to Song Brown, the application opens in April, it will close in May, and then the corresponding funding meeting will be held sometime in September of next year. Next slide. If you have any questions about the Song Brown program, any questions about applying for funding, please send your emails to songbrown@oshped.ca.gov. And this link here is to our Song Brown website. And that concludes my presentation. Thank you.
Thank you, Melissa. Appreciate that. We do have some time for questions. Are there any questions? You can either feel free to include them in the chat, or we're a small enough group that you can also just unmute yourself and ask. And while we're waiting to see if there's any questions, Christy, if I may just put you on the spot a little bit and perhaps share a little bit about what your experience has been in terms of funding and what is the next step for you?
Yes, thanks for putting me on the spot. It's
Sure.
I'm ready for it. We are still in the process of establishing the Psychiatry Residency Consortium. Just a quick overview for anybody who's not familiar. I know some of you are very familiar with what we've been doing, but we had a residency task force established with Butte Medical Society in August 2019. We made psychiatry residency our #1 priority. And in March and April of 2020, we were able to engage a consultant who then did a feasibility study, and that was exactly what we needed in order to get momentum. So my biggest learning point was the fact that the feasibility study is essential. And that's about, when you're looking at feasibility study, business plans, launching, it's a good $150,000 to $200,000 to just make that happen, which was a large sum for our community to fathom. So FYI, putting it out there to the universe, it takes money just to make it clear what is feasible or what isn't. And then we use that feasibility study report, which came out in July, to apply for OSHPD's WET PEC fund, and were awarded that of 1.8 million in September. However, the funds actually don't flow until we are accredited, and we believe that that accreditation would be available to us in fall 2022. So we are now in the unique position of raising money to get to the planning grant in 2 years in order to be accredited and then engage that funding stream to get into the full residency program. But we're also in the midst of really trying to figure out how this consortium is going to work. We had a lot of people at the table. We had open doors. We've invited everyone, and the dynamics of the community are what they are, and we're still trying to figure out what that consortium would be. And it would hopefully be through our 501c3 affiliated with Butte Medical Society, a new nonprofit, which is called Healthy Rural California. So those are all the things that are still being pinned down, and it's quite the process.
Thank you, Christy. Thank you for giving us an overview of where you are in the process, and being, just as importantly, being willing to share those lessons learned and being willing to share, this is the process as you've experienced it in your lived experience, as well as this is where either programs and or partners could support other interested community stakeholders that are going through the same process. So very much always appreciate that you're willing to share. Are there any other questions? I don't see any in the chat. Just give a few seconds to see if there's any other questions. Dean, it looks like you're going to say something.
Well, it's not really a question, and I've just been thinking about this for a while. My son is he just finished his internal medicine residency back in the Midwest, and now is doing a critical care fellowship in Omaha. But and we talk a lot about what he's seen back in the Midwest and to some extent the East, where they have embraced the creation of residency programs in many of those states to meet the needs of their states. If you look at Nebraska, for example, where he's at, they're not considered a shortage area for the most part. And that's because if you look at the number of training programs they have, it's unbelievable. And it's a mindset. And I've run into this here, and I'm not so much the big teaching hospitals, but I think you're talking about community hospitals, and you've got to have the buy-in of the physician community. And here it seems they look at it as, oh, this could be competition. I'm training to put myself out of business. Whereas the Midwest and the East, in many places, it's like, we're going to figure this out, and it's going to help us all. It's a different orientation, and it's a mindset that has always, it's been hard to get over, and because it doesn't necessarily mean competition. There's so many ways to leverage this to make it work for you and your community. So, I hope that it changes some, and because. And I don't know this, I haven't looked at all the raw data, but many of those GME naive hospitals, most of them must be community hospitals, I presume. And so they're going to run into this to a greater or lesser extent. And somehow to get that messaging that this can be a really positive thing, particularly if Medicare can come and pay for most of it, that is a big plus. But I'm just amazed at the barriers to it. And one other observation, we're up here, we have a couple family medicine programs, and we could certainly, our community could host an internal medicine program. We have one GME naive hospital that's looking at it. I always thought that an ER residency would make sense up here. As it turns out, they have Mercy Hospital up here is connected with Kiwia Delta down in Visalia, and they're going to start rotating their ER residents on a regular basis up here, because I suspect there must be a 6-6 program or something. There's only so much content you can give, you know. So we talk about new programs, but I'm wondering if there's a mechanism to kind of leverage programs that can get to the same place, you know. And just a general thought on that. So those are my brief sermon here on this stuff.
Dean, it's always wonderful to hear your sermons because there's always a lot of wisdom, certainly in terms of your experience, as well as, you know, what you're saying in terms of challenging the process. And your comments are super timely, given some of, even for example, the reports that came out last week that document what you already know. And I think I saw it posted on your LinkedIn around, there's this new report that documented 626 shortage areas, HIP says, in California. And it's like, yeah, we kind of already knew that. It was 500, 600. At some point, the numbers aren't as important because it's a lot. So I think that that's a really good point. And certainly there is a lot of just movement that we need to do it in the direction of collaborating, whether it's through a consortium model or a different model. But definitely, to your point, CHCF in one of the meetings that I believe you also attended had documented the number that Jennifer noted, 110 community or hospitals, I should say, that are GME naive health systems. And yes, most of them are community hospitals. Therefore, the challenges of collaboration versus competition, infrastructure, recruitment become that much more acute. Christy, did you want to make either a comment just in terms of like the community at large and how it's trying to move forward from a consortia perspective?
No, just what Dr. Germano was just explaining. Yeah, we need, it is fascinating how much effort is needed to bring a community together. Now, I'm experiencing this in 2020 with a pandemic, and I'm going to say that doing everything virtually, it was at a disadvantage for that. And so I'm just trying to picture what it would be like if it would be actually easier if we could meet in person to make all those things happen. But it's a lot of work, and what I'm drooling over these other states that just sort of have it in their repertoire and their vocabulary already to to bring residency programs together and do what it takes. That's definitely not necessarily what I've experienced here. And I'll just say that last year in 2019, there was more of a collaborative effort because of the campfire. So it shouldn't take a huge, terrible disaster to bring a community of healthcare providers and systems together. But that's what it was. And so we sort of came out of that experience with a little bit more collaboration. And then this year, just it's really rough. So.
Thank you, Christy. Hector, I saw that you unmuted and I wasn't sure if you wanted to chime in.
Yeah, I was going to send you a chat that you could put me in the queue. Thank you. And I apologize, I don't have a camera on my computer. So, but yeah, I like this conversation. I just wanted to add a couple perspectives that with this initiative that Mathematica is running with the GME naive hospitals, I'm working with a couple hospitals that don't have residencies. One is part of a larger system, so they have a medical foundation model where they're actually able to hire physicians. And so for them, there's a high motivation to get a GME program going. It'll populate their primary care needs. The primary care physicians that are employed by that foundation really are eager to have more primary care join them. And of course, the specialists, see that as a real strength in the market. the other hospital is a standalone hospital, and they are struggling with the issues that you and Dean mentioned, where the primary cares are kind of seeing that as a threat to their existence. And on the other hand, even they are divided because some of the primary cares have had a tough time recruiting colleagues, and so they see this as the perfect pipeline for them. And the others, I think, are closer to retirement, and I don't know that there'll be a major issue. So it does vary by region, but I think there's a business case to be made for this that was not there many years ago. And I think all the things that you described today with both programs, Song Brown and Cal MedForce, I think it just brings unprecedented resources that makes all of that much more possible.
Thank you, Hector. And if I might just reiterate your point with respect to the importance of collaboration and the importance of even programs like Cal MedForce, especially programs like Cal MedForce and Song Brown, working together, and sometimes it is very easy to get stuck in this place of like, this is our statute, or this is our frame of reference, whereas the opportunities to work together are so much more valuable and so much more meaningful. So certainly appreciate OSHPD's leadership in that area, and looking forward to seeing what else might come about with the new director when that person is appointed, and just also reiterating, Hector, your points about the importance of also having partnerships with other organizations like the California Healthcare Foundation and their support of Mathematica, and really finding those gaps, because as Christy mentioned, it's wonderful to receive a grant, but if the funding isn't available until all these steps are taken, then it just makes it that much more challenging.
Mm-hmm.
Thank you.
And the other question I have for both you and Melissa, if she's still on the line, and you don't need to answer if you don't have the answer yet, but with AB 890 being signed by the governor, the regulations still need to be written. But are you maybe in the back of your mind planning for a potential future where you'll have standalone nurse practitioner residency programs, coming to ask for funding, and how does that play out in the scenario that you currently have?
Melissa D, I know you're still on.
Yes, I'm still here. Thank you, Hector. We have had programs approach us about nurse practitioner residency program startups, but as you know, we currently don't have any funding for that. And I have not heard anything about providing funding for those at the moment. Nobody is currently discussing that at all.
Great, thanks.
Full disclosure, my health center has a postgraduate a nurse practitioner PA fellowship program, a 2-year program. We did it on our own, and we did it because I think people who are in the business can attest to, we found in the last number of years a tremendous growth in the number of PA and, well, particularly NP programs, because they tend to have more of an emphasis on primary care, but coming out with a lot less experience from their previous lives. The days of 6, 8, 10 years working the ER or the ICU and then becoming a nurse practitioner, we weren't seeing many of those. We were seeing people going to nursing school or PA school and, right into and it's really tough. So we did that. And now the Bureau of Workforce Professions at the federal level has had a couple of cycles of funding NP residencies. And they had heard a presentation, I think it was last week, that they have the legislative authority now to do more cycles, but of course they're waiting for congressional dollars to actually do it. So they're starting to recognize that there's an important place for such programs. And I think when we look at the real gap in primary care in our state, we know that some of that has to be filled by our NPs and PAs, and are being filled. But I think I just feel we're doing them a disservice, particularly the ones who are less experienced. I mean, heck, a family doctor has to go to, 4 years of medical school and then does 3 years of residency, before we put them out there. And we don't offer that same opportunity to NPs and PAs, so I do think there's a place for it. I hope in our planning at the state level, however that comes out, that some of that does start to show up on the funding side. I do think that with the new law that passed, I think there's so many hours that need to be achieved before an NP can become quote unquote independent. I would say that most of my NPs don't necessarily want to be independent. They want to be tied to a larger practice with MDs and DOs and others in an integrated way. So I do hope that we find a way to fund those kinds of residency programs. And I would say, even though NPs a majority, I do think there's a place for PAs as well in that training model. We're trying to do it. We're trying to get our program also accredited. I guess there's 3 accrediting bodies out there now doing NP and PA residency accreditations. So we need some consistency there as well. So.
Thanks for that insight, Dean. How long have you been doing it?
We've been at it now. We're in our 4th year, I think. It's small. We take between 3 and 5 at a time because we are a community health center. We're not a big academic teaching facility. The nice thing about residencies like that is that they come out with their licenses, right? So the patients they're able to see can be billable in our model. So that helps to compensate for some of the cost. And we went to a 2-year cycle because we found 1 year was not enough. So we do a lot of the didactics and all the, the groundwork in that first year. And we look at our second year as more of a transition to practice year. And we sort of build them up and get them to that second year. What we don't have is an academic affiliation. And we're talking with UC Davis about the potential for something like that. Some of the programs out there, like in Santa Rosa, they have an academic affiliation with Sonoma State. But, that would be a real plus to have that academic affiliation to go along with that. Hector, does that answer your question?
Yeah, thank you.
Yeah.
Really helpful.
Thank you. And I want to thank you both for a very interesting conversation around how will we address the access to health issue and how will we ensure that there is adequate support, safety, funding, et cetera, as we move forward in this continuum. And I think to Christy's point, the value of being in person as we collaborate and we challenge each other to find those best models or to be innovative in those spaces. And I think that that's definitely for Dean and Hector, the value of your leadership in this space, certainly as we think about how we're going to move forward, given new laws, et cetera, and given the challenges, given the elections as well, and are there opportunities there for us to rethink how we modernize Medicare funding, et cetera. So I want to definitely thank Dean, Hector, Christy, and everyone else who has joined us today. Again, this is an 8-part webinar series. So the next one, we will definitely send you information on the date and the time, as well as, look forward to having you invite others that you think might benefit from attending one of our series. So with that, thank you very much. And I hope you have a wonderful Thursday.
Thank you, everybody.
Thank you.
Thanksgiving.
Bye.
Same to you.